So my co-chair, Dr. Lennox, is going to give this overview of CROI. It's really a great talk that's going to cover the topics that we won't be covering elsewhere in the program today. So Jeff, welcome back.
Thank you, Michael. You know, when you go to CROI, there's several tracks, and everything goes on simultaneously. The nice thing now about CROI is that you can look at the slides and the talks online, and they open it up to the public, and I believe we're beyond that point now. So I encourage anybody who wants more information, because I'm summarizing things. If you want to go watch the talk, they're absolutely excellent. And it's not quite like streaming on Netflix interest, but it's pretty interesting. So I chose things based on what I thought would be clinical applicability. There was tons of interesting science there, and Dr. Dueck covered quite a bit of it. And you know, hopefully we are edging our way towards a cure. I'm always thinking, though, about the famous statement by Dr. Ho in 1996 that we would have a cure within 3 years. So we're edging up on the 20th anniversary of that, and maybe we'll get there before too many more years pass. These are the learning objectives. We're going to go over each of these areas. So antiretrovirals, long-acting treatment, and then a few general management issues for HIV-infected patients. This study I thought was very interesting. We all know that we have long-acting injectable antiretroviral therapy, right? This is not a new thing, but some people don't want to come in and get shots. You know, some people do, some don't. And a lot of people can take one pill a day, no problem, and a significant proportion of people can't. And so having long-acting therapies that aren't injectable might be beneficial for certain groups of people. And this is edging towards that goal. Now, ideally, you'd have one pill once a year, similar to the one shot that Dr. Dueck was saying for a cure. We're probably quite away from an oral pill that you take once a year. But this was an open label trial of islatravir and lenacapavir. So both of these are currently available, although the lenacapavir formulation here is oral. And so it was not the standard formulation that's available to us now. So people who were on treatment, who were fully suppressed, high T cells, no history of virologic failure in the past, so no suspicion of resistance, they were randomized 1-to-1 to continue what they were currently on, or to switch to islatravir dosed weekly at 2 milligrams, and then lenacapavir at 300 milligrams orally once a week. And so these were both given once a week. The reason the islatravir was 2 milligrams, I think people probably remember that several years ago, islatravir looked like it was about to leap onto the scene, but then there was problems with lymphopenia at the doses that were being studied. And so that delayed the further development of islatravir. Now at this 2 milligram dose, data is indicating in small groups of people that there's less lymphopenia, and we'll see more data on that from this study. So these are the baseline characteristics. You can see there were 52 people in each arm, and you can see that they were roughly equally matched between the two arms, and the mean CD4 count was slightly higher in the arm that continued on existing treatment, but that's really, you know, not really a significant difference between the two arms. So this is the results looking at viral suppression. And what you can see is that in both arms, 49 of the 52 people, so in the arm that continued their standard or the arm that switched to lenacapavir, islatravir once weekly, there was no difference in the rates of viral suppression. Now you can see that there's a few with no data, and then on the left side, there was one person who had detectable viral load at the point of primary endpoint. And so you would technically call that a virologic failure on the once weekly regimen. But what you can see on the bottom is that at screening, this person was undetectable, and that at entry they had 251 copies, and the number of copies fell throughout the course of the study. So even though that person's technically a virologic failure, you and I as clinicians would say that this was a virologic success because the person had had a slight bump in viral load prior to being switched and then became suppressed while on this once-weekly regimen. This is a concept that the company is moving forward with and doing a larger study looking at once-weekly dual treatment with this regimen as a potential therapeutic option moving forward. Now, looking at the safety, you can see that there were more safety events, any event in the lenacapavir/islatravir arm. Most of these were very, very mild and were felt not to be related to the drug. There were 3 serious adverse events. Intestinal perforation, maybe that could be related to the oral drug. Acute hepatitis B is probably not related. And then a complication of anesthesia, clearly not related. So it appears in this small study that these are safe. And then if you look at the absolute lymphocyte change, there's a numerical difference where there was slightly increased lymphocyte decline in the islatravir lenacapavir, but it wasn't statistically significant, but it's only 52 patients per arm. So this is something that we need to look at a larger trial with islatravir at this reduced dose and see if it holds up that it's equally safe as continuing on existing antiretroviral therapy. But theoretically, it could be a few years, and this might be a once-weekly oral regimen that would be available for treating patients, particularly those who are already suppressed on a daily regimen. Now, companies are continuing to develop other long-acting antiretrovirals. This is an example that I chose from one of the oral presentations looking at pharmacokinetics of a weekly oral INSTI. And a previous study had suggested that given the half-life, that this integrase inhibitor could be given once a week. So this was a phase 1b dose-ranging study where they chose people who had CD4 count greater than 200, a detectable viral load, but less than 400,000 because they didn't want to give it to people with very, very high viral loads. And most of them were treatment naive, although a few people were allowed to be enrolled who were treatment experienced but integrase naive. And they checked 3 different doses. You can see them at the bottom there, ranging from 30 to 900 milligrams in 7 patients per dose. So this is a classic small dose-ranging study to try and tease out what dose you might move forward with into a treatment study. And what you can see is, I hate this historical placebo they put in there. I don't know why you would put in a historical placebo. That's ridiculous to me, but I use their image so just so that I could mock them. But what you can see is there appeared to be somewhat of a dose effect in that the 30 milligram dose had an equal decline initially, but then a return or a slowing of the rate of decline is the correct term, by day 11. But the other 3 arms all had similar levels of decline, dropping the virus load by more than 2 logs, which is what we would expect from an integrase inhibitor. So the pharmacokinetics support once-weekly dosing, and this small study would indicate that perhaps a 150 or a 450 milligram dose would be sufficient for therapeutic efficacy. There was no emergence of resistance in the 2 arms that had been tested, and they chose the 150 and 450 for the obvious reason that those are one of those 2 arms they're looking forward to going forward as their selected dose. And then they're also going to check in the 30 milligram arm where they seem to have some leveling off. So they may discover some resistance there. But so far in the 2 doses that might be therapeutic candidates, they didn't see any resistance, which is good. Although 11 days, obviously, you may not detect it. If you were to continue monotherapy, you'd probably lead to emergence in a lot of people. So again, once weekly INSTI with a once weekly oral drug like we talked about in the last study, there may be a couple of different options to use once a week for people. Now, Dr. Dueck, I think, showed you the positive sides and the negative sides of some of the BNABs that are being used immunologically. There are several BNABs that have been used therapeutically, and there were some study results from the retrovirus, and I'd just like to show you a few of them. I'm not presenting every single one because there was posters and other things, but these were ones that met the criteria to go into the in-person presentation. So the Banner trial is a dose-ranging study in antiretroviral naive people with detectable viral loads. They were given a dose range, which you can see in the table here, of a CD4 blocking. I mean, that's not really what it does, but to me, to my brain, that's saying, okay, you're blocking the virus from binding to CD4 is how this particular antibody works. They gave them one dose, then observed them off of antiretroviral therapy, and then watched to detect a rebound in virus. And what you can see, they gave them 1 milligram, 4 mgs, 10 mgs, 40 mgs, or 10 mgs per kg sub-Q. So they tested both intravenous and sub-Q formulations. And you can see that with this dose increase, again, there appeared to be a dose response. The low dose had only a half a log, similar to what we used to see with zidovudine monotherapy. And then the higher doses got over 1.5 logs, similar to what we used to see with 3TC monotherapy, a pretty active drug. You can see the time to rebound following the nadir in viral load. And what you can see is there appeared to be a dose effect there too. The people that got 1 mg per kg rebounded in 13 days after the nadir, and the people at the higher 2 doses rebounded much more slowly. Now, unfortunately, the sub-Q didn't work as well as they had hoped. It had less of a viral effect and a quicker time to rebound. They may need to go back and reformulate it and try again. But for now, like most broadly neutralizing antibodies, this would be given as an intravenous treatment. And so they are planning to advance this. Well, it's actually, I shouldn't say planning, they advanced it into an ongoing trial. They didn't really say which of these doses they advanced into, but they are ongoing with this monoclonal antibody plus a long-acting cabotegravir in a trial called Embrace. And they intimated that we would see the results of this relatively soon. If I remember correctly, it was in about 1.5 years. Now, another way to go about doing it is to try and maintain suppression of viral load using a broadly neutralizing antibody, not as monotherapy, but with something else. So similar to what we do with cabotegravir and rilpivirine, in this case, it would be cabotegravir plus a broadly neutralizing antibody. So 71 suppressed patients were switched to getting monthly cabotegravir, and every other month, the VRC07 modified to give it a longer acting. So this is one of the monoclonal antibodies that there's been a few trials with, trying to determine its antiviral efficacy and half-life. And the longer acting regimen formulation was chosen for this study. Again, VRC07 binds to CD4 and interferes with virus binding. 66 of the 71 patients that were switched to this monthly CAB plus every other month injection of the broadly neutralizing antibody remained suppressed. Now, of the virologic failures, 3 people got vaccines in a short interval before they had a viral load measured. 1 person had continued low-level viremia that never escalated, and 1 person was an actual failure and developed a cabotegravir mutant. But 66 out of 71 is pretty good for viral suppression. The thing that worries me about this is, thank you. is the 3 that had significant viral, I'm not going to call them a blip, but they were detectable viral loads after a vaccine, indicating again that activating the T cells can lead to viral replication. When we know with triple drug antiretroviral therapy that usually doesn't have a whole lot of clinical impact, but this is a different setting, and whether we would be encouraging mutants that developed resistance to the broadly neutralizing antibody, I think remains to be seen. Another similar study using different agents, again here lenacapavir, and then if one broadly neutralizing antibody works pretty well, why don't we give 2 and it'll work even better, so that you're attacking the virus from 2 different directions and inhibiting its ability to replicate or to infect new cells, I should say. So in a prior study that Dr. Iran had done from North Carolina, they showed that people with HIV that were susceptible to both of these monoclonal antibodies, 18 out of the 20 of them remained suppressed. And they said, well, maybe you really don't need to. Let's do a trial in people that their virus is only susceptible to one of the 2 monoclonal antibodies. And so that's what they did. They took people who in vitro had susceptibility to only one of the 2 monoclonal antibodies, and they gave them these 2 monoclonal antibodies plus lenacapavir in 2 dose levels of one of the monoclonal antibodies. And what you can see at week 26, viral suppression, there were 2 people out of the 10 that did not remain suppressed, and they're doing additional studies to see if they had emergence of resistance to the other broadly neutralizing antibody, or if this is just an epiphenomenon. And so they didn't have those data available, but it's a little concerning that in this really small study, 2 out of the 10 people didn't maintain suppression, and more data will be coming. So before we go on, the advantage of these long-acting broadly neutralizing antibodies, obviously, it would be that they don't work inside your cells, so there would be much lower potential for cytotoxic toxicities. And so they might be great ways to suppress people's viral load with intermittent infusions, so the long-acting ones maybe even 4 times a year or maybe even less. So I do think that there is some reason to think that these might come into clinical practice, although obviously whenever you're giving an intravenous infusion, it increases some of the complexity. Now, one study I thought was really interesting was using long-acting antiretroviral therapy in Africa. And I think most people in the audience are aware that, for over a decade in Africa, we were using oral antiretroviral therapy that was mostly efavirenz based. And then there was a switch to integrase-based therapy. And then now the question is, for these people who are doing well on treatment, could they be candidates for long-acting cabotegravir-rilpivirine? Now, the problem being that the resources to do all the resistance testing and look for, archived resistance, they're not really available in a lot of settings outside of Europe and North America. So this study, they randomized people who were on TDF-3TC dolutegravir to go on to Q2-month rilpivirine and cabotegravir or to remain on the standard of care. And they didn't check for archived resistance when they made the switch. They just switched them. But they went back and did the resistance testing. And what you can see is the baseline people that were on an integrase prior NNRTI use, and then archived rilpivirine resistance, it was about 10%, roughly, had already rilpivirine resistance, and a slightly higher percent, especially 10.5 in the cabotegravir rilpivirine arm, had cabotegravir resistance. So you're switching them to a long-acting treatment where they already have resistance to one of the 2 agents, at least based on the archive resistance testing. And then they looked at 48 weeks after the switch, and what you can see is that in both arms, 97% of people remained suppressed. So since 10% had resistance to cabotegravir, you would expect that to be 90%. So it appears that either the archive resistance testing isn't detecting replicating competent virus, which is possible, or that rilpivirine is much better than we think. So it's really unclear what to make of the results. Now, 2 people did develop failure with cabotegravir resistance, but still this was a fairly large study, and so most people did very well. And so the thinking behind this is, in areas of the world that didn't have the luxury of all the resistance testing that we do, is it safe to potentially switch some people to long-acting injectable antiretroviral therapy? And it appears based on this that, at least for one study, most people did fine, although obviously it's never good when you develop resistance to cabotegravir, although now we have newer drugs like lenacapavir and potentially islatravir and others to fall back on. In the last few minutes, I'd love to cover some non-antiretroviral associated conditions. One of them is obviously obesity. We've had lots of talks on obesity and metabolic derangements, and I don't know about you guys, but semaglutide, it seems like everybody, including half of my patients, want to be on semaglutide, Wegovy or one of the others. And there haven't really been great trials in HIV-infected people to see how effective it is. So this study was a randomized, double-blind, placebo-controlled trial that excluded those with diabetes because they didn't want that confounder in there. And it included people with BMIs greater than 25 on ART. You can see there was 54 people in each arm. So the figure on the right side of the slide shows the trial design. And they titrated the dose up like you're required to do. And then they looked at the full dose effect over time and saw what the results were. And as you would expect, people lost visceral adipose, they lost peripheral adiposity, lean body mass decreased, and body mass decreased. So it's not just that you lose fat. Carrying around a lot of fat actually stresses your muscles, and if you don't add exercise to this, it wouldn't be surprising that you might lose some lean body mass. They looked at high sensitivity CRP and soluble CD163, which are different markers of ongoing inflammation. And you can see there was a drop in these 2 inflammatory markers with the semaglutide. So this looks great, but 5% body mass loss is not what our patients are being told. Everybody thinks they're going to lose 150 pounds, and did not happen in this randomized trial. Now, the CENIX cohort of a consortium of HIV clinics in the country looked at people who went on semaglutide, and what they saw again was about a 7.5% weight loss, which was a little bit less than 20 pounds. So people are losing weight, which is obviously a good thing, but we don't know if it's similar to people that don't have HIV. There's not been a good randomized trial, and it may not be quite as much as people without HIV. Now, one thing that's really bedeviled me as somebody who's interested in hepatitis B and hepatitis B vaccine responsiveness is how resistant some people are to developing a protective antibody response. And I'm sure everybody in the audience that treats patients has, we've given them the primary, we've given them the secondary, we've escalated to the dialysis dose, and still people don't respond to the vaccine. And depending on the cohort you look at, it's somewhere around 10 to 20% of people just don't respond to hepatitis B vaccine. So there's a newer vaccine that came out a few years ago that uses a TLR9 adjuvant that can help stimulate, as Dr. Dueck pointed out, T-cell responses and hopefully potentially antibody responses. So the ACTG did a study where they took people who had not responded to previous hepatitis B vaccines. They also included an arm in people who are treatment naive or vaccine naive, but really the major part of the study was to look at people who hadn't had a good response before. And they randomized them to get another course of a standard vaccine or to get 2 doses or 3 doses of this newer Hep B vaccine that has an improved adjuvant. And you can see the vaccination schedule on the bottom. They vaccinated at 0 and 4 weeks for everybody, and then at 24 weeks for the standard Injectable, and 24 weeks for one arm of the Heplisav, which is the trade name. And you can see here that there were some seroconversions with the standard Injectable, but with the Heplisav, you had both arms, both the 2-dose and 3-dose, had significant responses. Over 90% of people responded versus about 60 to 70% with the standard. So I thought this was very exciting, and to me would indicate if somebody's already failed a couple of rounds of hepatitis B vaccine, that this would be potentially an intervention to try to see whether they would then respond to the Heplisav. Now, this is an interesting look at subgroup responses and titers. And we know from previous studies that certain subgroups of people are more likely to be non-responders. And so if you look on the left, you can see by age, CD4 count, viral load, and I can't even read my own slide. Oh yeah, years since last hepatitis B seroconversion. And what you can see in the blue dots, which is the newest vaccine, it worked across these categories. So people with low T cells, people with high T cells. I mean, they weren't doing it in people with 10 T cells, but across a gradation of T cells, you had pretty much equivalent responses. And then if you look at the titers, what you can see is that of those who responded, you had better antibody titers, so higher titers of protective antibody in people that got the improved vaccination. One thing that I put in here, and you'll hear more about this from one of our later speakers, is there's been a lot of resistance about using meningococcal vaccine to protect against gonorrhea. And there were 2 studies that indicated partial protective activity of a meningococcal vaccine against gonorrhea. This was one that was presented at CROI. I'm sure she's going to talk about it more. It was part of a doxy-prep study where there are 2 arms looking at doxycycline versus no PEP, and then the meningococcal vaccine versus no vaccine. And what they showed is that in an interim analysis, which we covered last year that was reported at CROI, there appeared to be benefit of the vaccine. Now, subsequently, they discovered that they lost a file that had most of the patient's results. I don't know how you don't even see that you don't have most of the people's results in your interim analysis. And when they found the file, there was no longer protective efficacy at the same time point that it had been studied before. So it still seemed like it separated out after the protocol-defined endpoint. So I don't think we can say this is a failure of the vaccine. I do think that the other studies indicated partial benefit. But I think now we need even more analysis and potentially looking at collated data between the trials. But it was highly embarrassing, and one reason I wanted to present it is I remember that it had been talked about at our previous lecture. I didn't want people to not hear the latest update about the snafu. And that's the end of my talk, and we'll go ahead and stop and open it up for questions.
Great, thanks, Jeff. You can stand or sit, whatever you're comfortable doing. So very nice. Again, encourage you to come to the microphones. If you have questions, you can also put them in on Slido. Regarding that last presentation, I spent a little time we have these IAS-USA podcasts, which I can't plug too much, but they're pretty good. And we talked about 6 people at CROI, one of whom was Jean-Michel Molina, who was in charge of that study for the meningococcal vaccine. And it does sound awkward that they lost a file. It wasn't that it was lost, it's just that it wasn't included. And he said he felt uncomfortable at the very beginning presenting interim data. And I think that's the lesson, is that we get in a hurry to kind of get our results out. You can do statistical assessments to kind of look for significance and adjust with Bone-Ferrari or whatever statistical approach to kind of convince you that you're doing it properly. However, you set up the study initially to be powered a certain way, and waiting for the full data set to come in is generally a good idea. So I thought it was very honorable what he did, and not easy. He'd stand up and say what I presented last year was wrong, but he didn't feel right at the very beginning, and I think that's a good lesson for all of us to listen to our gut when we're doing these types.
It's easy to get excited about positive results, right? You see a difference, so you suspend what should be your disbelief, which should be your baseline. But yeah, I thought he was very gracious in acknowledging that there had been an unanticipated problem and took responsibility for the previous presentation.
Yeah, please. Morning.
Morning.
I think just keep talking. Yeah, they'll get it.
Webinar last Friday, IAS, it was Judith Courier and I want to say Eric Garr, did sort of a CROI update also, and talked about some of the hepatitis B issues, and realizing this is not a hepatitis B conference, but I was very confused because he seemed like he was saying that if you're Hep B surface antigen negative, core positive, surface antibody negative, that maybe you should vaccinate them.
Yeah, that's going to be, we're going to do that in a case here.
Melanie's going to talk about that exact issue. What do you do in that situation?
But but you're right, it's sort of an emerging thing. It doesn't happen that often. Does everybody follow what we're talking about here? Yeah. And a lot of times we don't even order the core antibody, right? But it seems like when you're using interventions that don't have a hepatitis B agent like tenofovir as part of the regimen, it becomes a possibility that there could be a flare down the road. But I'm glad you brought it up because we will be getting into it in a couple of the lectures coming up. But thank you, that's really important. While you come to the microphone, there's one question here about how was it that so many patients in that African study with cabotegravir, how did they have baseline resistance to cabotegravir?
We're now about, 5 years into the dolutegravir rollout.
Yeah.
So, and people were on dolutegravir. So some people, and this is well reported in Africa, that have gone through 3 or 4 different rounds, when they got onto their dolutegravir regimen, they're failing with resistance. But it's actually fewer than many people anticipated. People were expecting disaster, and it's actually working better than was anticipated, but it's not working for everybody. So those people, it's most likely a cross-reactivity between dolutegravir and cabotegravir resistance because they're continuing on the dolutegravir. They're not taking people off because their viral load has gone up because they don't have a salvage regimen. And so people are still benefiting. Or do you have a different opinion, Mike?
No, I agree. I think we might have skipped over an important detail that is dolutegravir and cabotegravir molecularly are very, very similar. So if you get resistance to one, you're going to have likely resistance to the other, just pharmacologically. Yes, please.
Hi, good afternoon, good morning. Thank you, Dr. Lennox. I was trying to see the slides for your lecture, but I don't think they're in here in the e-syllabus, so I don't remember what the dosage was on the semaglutide. Was it 1 milligram that it went up to, the titration? Correct. Was it 1 milligram? Because it's important because for me, like semaglutide and bictegravir are 2 of my favorite things in the world, and I put a lot of my patients on both of them. Mm-hmm. So it's something that I've just done anecdotally for me, right, and for my patients. But there's a big difference between like a 1 milligram dosage of weight loss in semaglutide versus a 2.4, which is the maximum dosage for weight loss. So I think it's important to note that if the study didn't titrate up to the 2.4, you're not really giving, because I'm just looking at the label right now myself, and like 1.7 was a difference of like a drop in 9.6 versus 13.2 if you were at the 2.4. So I think we, have to mention that. I know it's not been studied in the HIV population. Like I said, anecdotally, my HIV patients lose weight. Then their diabetes is like pre-diabetic. It's just a miracle in my opinion.
No, I don't want to give the impression that we shouldn't be using these, and certainly I've got several patients on the exact medication we're talking about. They did not escalate everybody up to 2.4. Not everybody can tolerate the
No.
escalation.
No.
So you could criticize and say, well, you really should have, done an analysis of those who were on 2.4 versus 1 versus 0.5, et cetera.
And
So
I'm
this
not
is not
criticizing,
is not a definitive study. The reason I presented it is we haven't had any data in people with HIV, right? We don't even know if it's safe. So I think it's good that it worked. I do think that this is a really difficult problem because what are the long-term side effects of this medication if we're going to continue it for 10 years? When can you stop? What's the safety over the long term? There's a lot that still needs to be worked
And
on.
I think, when we think about aspirin for primary prevention for heart disease, and we have a MACE reduction that's 20, it's on label to prevent cardiovascular,
Right.
First. And so my opinion, as also someone who's been on Ozempic for 5 years myself, it's my investment of once a week to actually affect my cardiovascular health, keep my A1C at 5.3, and never hopefully seeing something over 6.5 again. So I know. So I just wanted to say I feel like there's a lot of benefit to the HIV population just because of the.
I think you're really going to love Dr. Greenspoon's presentation
I didn't even know
later.
that was going to be part of today. I came down from New Jersey just to hear Dr. Sagg's choices for Broadway show tunes and stuff. But sort of not so far from the truth. But when I saw the semaglutide, I thought I'd died and gone to heaven. So anyway, I just wanted to say that I'm a big fan, and if a bunch of people get on this and they never get diabetes and they're not obese anymore, I'm for it. So.
And I agree. I'm very cautious, however, because I've lived long enough and been through enough to see these unanticipated late toxicities, and I'm very much on board with this, but I'm very cautious in my interpretations of things. But I think you're going to love Dr. Greenspoon's presentation because he's going to go into a lot of the things that you just talked about with MACE and percent decrease, et cetera. So I do think this is like our number one problem for our patients now, right? Obesity, comorbidities, cardiovascular diseases,
And then they gain
stroke.
weight, like the whole oh my gosh, bictegravir is great, but everybody's gaining weight, so it's kind of.
So this is something we're all dealing with, and we're going to have to figure out how to do better. Thank you.
Yeah, and there's just a comment here, I think like all of us are struggling with about access to semaglutide, but when you can get it, it's being used a fair amount. The scenic study that Jeff referenced also picked up from 10 clinics around the country that is getting used, but gaining access is difficult. There's also a question here about the role of the ACWYB meningococcal vaccines. I think, is Melanie getting into that? I don't recall if she's going to talk about that directly.
I think so.
Yeah, and we can, good. So we'll hi, Melanie.
My slide was more of a teaser for Melanie's talk.
Right, and she's going to get into details about the BHAV study. Right. One final question, going back to Africa. Just the lesson that we should be testing for integrase inhibitor resistance before we give cabotegravir here?
Here in the U.S.?
In the U.S. We aren't doing it, I don't
Some people are doing it, but they're still making the switch, the ones that I've seen the presentation. So I personally don't think that there's evidence that it's indicated. Yeah. I mean, are you going to cover that in your cases? Or?
Well, we will talk about that a little bit. The other question here, I guess, goes to Dr. Greenspoon in just a minute about the PCSK9 drugs when you can't use a statin. We'll make sure we get to that in the Q&A there, but we're out of time here. I'm going to turn the moderating over to you, and thanks very much for a great talk.
Okay, I think we're due for a break.